Lynette and Scott, thank you so much for the invitation. I'm really happy to be here today talking about COVID and nurses. So I'm going to go ahead and share my screen. So, one of the reasons I'm particularly excited and pleased to be talking about this is that right now nursing is the nation's largest healthcare profession, and there are nearly 4 million nurses nationwide. And of course, there are even more when we start to think about licensed vocational nurses and practical nurses, as well as nursing assistants. And these are all groups who have been on the front lines of the COVID-19 pandemic, providing patient care. And in the course of providing that care, they have, of course, encountered numerous ethical issues. Interestingly, though, relative to both their size and the fact that they've had such a critical role in providing patient care, I think that nurses have been relatively underrepresented in discussions about the ethics of the pandemic. I don't want to say that they've been entirely absent. Georgina Morley and other nurses that I hugely respect and admire, including Christine Grady and my Penn colleague, Connie Ulrich, have written pieces I would recommend. Georgina led a piece in the Hastings Center report, for example, looking at COVID-19 and ethics for nurses, as well as a really great JME blog. I would recommend to people who are interested in reading more about this topic when this is over. All of that being said, I do want to highlight a few issues that I think are particularly salient for nurses. So first is access to personal protective equipment. I want to talk about rationing. Nurses, both as those who ration and also people who are themselves rationed. And then I want to think about some longer term effects of COVID-19 for nurses, including moral and psychological distress, as well as long-term economic effects on nurses and the nursing profession. But first, I think it's important to go ahead and acknowledge the death of George Floyd and other Black men and women at the hands of the police, as well as to acknowledge the protests for justice that have resulted in the US and around the world. So I chose this particular picture for this slide because it really is a picture of a pandemic within a pandemic. We see people, protesters who are wearing masks, as well as asking for racial justice. And, we know the Black community and the minority community has really carried a disproportionate burden from COVID-19. This is true for their health and well-being, as well as economically. And racism is, we should acknowledge, a real public health concern, and we can see it in the midst of this pandemic because pervasive racism has in fact allowed COVID to disproportionately affect Black and other minority communities. So nationally, African American deaths from COVID-19 are nearly 2 times greater than would be expected based on their share of the population. In a few states, about 4, the proportion is even greater, so it might be 3 times greater or more. And meanwhile, we know that white deaths from COVID-19 are lower than their share of the population in the majority of states. So what I take away from all of this is that nursing is one of the most trusted professions, and I really am hopeful, based on things that have already happened, statements from the American Nurses Association and others, that nurses will take an active role in addressing racism and really taking this moment to reflect on what the profession can do to address health disparities, and really, as my daughter would say from her Quaker education, be upstanders, not bystanders. So acknowledging that larger context, I do want to turn and think about some issues that have addressed nurses in particular. So early on in the pandemic, there were pictures going around on social media and in some news reports about nurses who, for a lack of personal protective equipment or PPE, were wearing trash bags. And over time, I think that, given the sweep of current events, it's unfortunate that that has really been a message that has receded from the public eye, but many nurses still across the country say that they don't have enough personal protective equipment, or they're being required to reuse supplies, including N95 masks. And before COVID-19, that would have been considered not standard of care or substandard to do those sorts of things. So when we think about the lack of PPE, this persistent lack of PPE, there are 2 messages that I really wanted to stress today. So the first of these is in conjunction with the narrative that we often see in the media that nurses and other frontline healthcare providers are heroes. I know for some people that message is really empowering and uplifting. People have appreciated things like clapping for healthcare workers that we've seen in the US and also internationally. But I just want to problematize the healthcare hero narrative a bit. The problem with that is that it really emphasizes bravery in the face of hazardous conditions, and nurses are being brave, but we don't want to lift that up as an unqualified good and fail to acknowledge that the continued existence of these shortages really months into the pandemic is a direct result of failed responses from state and local government. And I think that the hero narrative can sometimes be a little stifling and not leave room for seeing the shortage of personal protective equipment and the follow-on consequences that I'll get to more in the next slide for healthcare providers as a real problem that we need to address. The other issue that has arisen in the context of PPE is that some nurses have publicly spoken out about the shortage of PPE at their hospitals, and they have found themselves retaliated against by their employers. So they've raised legitimate concerns about their safety, but then are intimidated, ostracized, or fired in ways that are problematic. And I think that not only is this ethically and morally unacceptable, but I'll be interested to see what sort of litigation might occur after the case because of this firing for raising the alarm on a real problem. So in part because of a shortage of PPE, COVID-19 has killed more than 300 US healthcare personnel. Those are the latest statistics from the Centers for Disease Control and Prevention. It's not broken out by the CDC in terms of nurses, but more than 600 nurses have died worldwide from exposure to the coronavirus and infection, making this an issue not just nationally, but internationally. And that 600 statistic was actually reported just yesterday. In terms of this obviously has personal consequences. I don't know if anybody else heard this story on NPR this morning. It was on Morning Edition, where a woman offered a remembrance of her mother who had died from COVID-19. The mother was a nurse and had been infected, they think, at work. The other thing that's worth highlighting is that this 300 number that I'm offering here from the CDC is likely an undercounting. There's really been a tremendous patchwork of state tracing and as well as federal data collection. And a number of people are dying at home and not being counted, or they're not getting tested, and so the deaths aren't being attributed to the coronavirus. And this really means that the true toll of COVID-19 on US healthcare professionals, as for the population broadly, is not being accurately counted. And in terms of this photo, I just want to highlight that this is a photo from May 7th. It was a protest at the White House where nurses assembled and they put out empty shoes for their colleagues who had died as a result of coronavirus, and then they read their names aloud. And at that time, so May 7th, about a month ago, they were able to read aloud names of 46 nurses who had died in the United States from coronavirus. Another issue to highlight is really rationing and how that relates to the provision of nursing care. So when we talk about rationing for nurses, we need to account for two different things. So first is the role of nurses in rationing. So when we talk about developing triage plans, for example, nurses really have a crucial role in making those triage plans operational. They're going to be there to assess patients when they present to the ER. They're going to be responsible for administering care at the bedside. And as a result, I think it makes sense, and we can make a logical argument that nurses who are involved in executing triage plans should also be involved in developing those plans. So there's been a lot of talk about the need for bioethicists to be involved, but healthcare leaders and other people developing these plans similarly need to recognize the expertise of non-physician healthcare providers, nurses, and others during times of emergency and bring them to the table. I think that as an editorial comment that it's been interesting to me that when nurses talk about bioethics, they're often described as a nurse bioethicist instead of just being a bioethicist. And I think this highlights the ways in which the physician perspective is really implicit in the idea of bioethics frequently. And nurses need to have a seat at the table because their experiences are maybe, you know, they share certain commonalities and features, but they really do have a distinct lens through which they see things. The other important part of the role of nurses in rationing is that as the people who are most often there at the bedside administering care and interacting with families, when you think about a 12-hour shift and just the sheer amount of time that you spend getting to know your patient and their loved ones, we really need to help them know how to talk about difficult things like rationing at the bedside with families, given the potential distress for patients and families. So that's the sort of scarce resources and equipment side of things. But the other part of this is to really think about the reality that nurses are themselves rationed. So we focused a lot, especially in the beginning of the pandemic, when there was so much concern about the shortage of ventilators in particular. But somebody has to be there to operate the ventilator and take care of a patient who has that level of acuity. And I could make the same argument about patients who are connected to ECMO circuits or continuous dialysis circuits. And as somebody who was an ICU nurse in what feels like a previous life, I can say that that really requires an incredibly complex skill set to have those things and to be able to provide that level of patient care. And so when you have a number of patients who need that kind of intensity of care, but a finite number of nurses, nurses themselves are rationed. So this might be through nurse to patient ratios. In some places, this has been particularly contentious, given that in some states like California, where I practice, those were fixed by law, but in other places, they're much looser. And the other thing is that, we have, of course, there have been efforts to try to surge nurses and to have more nurses available. But what this means is that some nurses have been assigned to work in unfamiliar units, with patients who are outside of their area of expertise. Maybe they're floor nurses who have been brought to an ICU and aren't used to providing that level of complex care. And because of the time demands, they really haven't gotten any training to move into those roles. And that can be incredibly frightening. The other thing that we've seen happening is that in an effort to meet demands, states have worked on different ways to expand the nurse workforce. So some states have issued waivers for nurses who have inactive licenses so that they can temporarily enter the workforce and meet requirements like with minimal refresher time. And I have really the utmost respect for people who have come out of retirement or who have reactivated an inactive license for whatever reasons that they have chosen to go inactive. I myself had gone inactive due to the decision to go on to graduate school and then to step into academia and away from the bedside, and looking into thinking about how you can reactivate your nursing license. It does speak to this idea that you really want to contribute to this national health crisis, and at the same time you have to recognize with humility the limitations of your own skill set. In my case, I hadn't practiced in an ICU setting for a decade, and feeling that tension between wanting to be back and also realizing that things are a little dusty, literally and figuratively. There have also been some questions legally about licensure and nurses who have licenses that have been suspended, say for a disciplinary violation, and whether or not there was space to go ahead and allow them to practice in spite of that. So some of these issues have receded a bit as the initial surge in patients has tapered off, fortunately. If we have a second or third wave, I think we're going to have to continue to address these questions about which nurses can practice, in what settings, and with what support. So the discussioning of rationing, I think, flows very nicely into a discussion of the moral and psychological distresses that nurses are experiencing now, and we need to be aware of that in the moment, but we also really need to think about the long-term effects that are there for nurses. Previously, I mentioned that many nurses are being asked to care for patients in settings that are unfamiliar or with a level of acuity that they're not prepared for, and that can be very difficult. It's also the case that there are changes in the standard of care that can occur in pandemic circumstances like this. Due to a limitation of resources, we might be shifting what we would offer patients as compared to normal, if we could define what normal is. And so in pandemic situations like this, nurses can really experience a tension between the care that they feel like they should and would like to provide and the care that they can in fact actually provide given the circumstances that they're confronted with. And that can lead to a level of moral distress. Nurses are understandably also worried about risk to themselves, again, highlighting that these issues are all interconnected. So the lack of personal protective equipment, knowing that nurses have been infected, knowing that nurses are dying, not necessarily having clear guidance on when it's safe to come back or access to testing. And so here you can have concerns about how do you best take care of yourself, how do you best take care of your patients, and how do you manage risk to your family members. And so there's been some nice work done by the American Nursing Association. Cinda Rushton has done some of the work on this, but how do nurses balance the tensions between providing care and keeping themselves safe? And oftentimes in these systemic crises, if you don't have adequate protection, the answer is actually that maybe you're justified in stepping away from the bedside, but that itself can be another cause for moral distress. The other thing I want to highlight here is that, nurses are always experiencing moral distress in practice. I can still think back to things when I practiced that continue to cause me a certain amount of pain. And when we think about the emotions these nurses are grappling with, the rationing situations they're confronting, the morbidity and the mortality of their patients, we really need to think about what kind of safety net we can put in place long-term to help them both develop moral resilience and to be prepared going forward to avoid burnout and to make sure we don't inadvertently create a provider shortage because we have exhausted the nurses that we have on the front line. Another issue that we're starting to see emerge is that there are tremendous economic consequences to the pandemic. Of course, we know that there are some 40 million Americans, and the numbers are growing, who are currently unemployed. But one of the great ironies here is that the healthcare system, even as we see tremendous demands placed on it, has also seen tremendous losses. So the healthcare industry lost an estimated $500 billion during the first quarter of 2020 because there were fewer appointments, there were fewer elective procedures, there was a lot of revenue that was lost. So the federal government has put out various stimulus packages that were meant to help shore up and address that lost revenue, but it accounts for only about a third of what was lost in the first quarter. And that means that hospitals are facing budget shortfalls and now have to make difficult decisions about what they're going to do. And unfortunately, some of what this has meant is that nurses are being laid off and furloughed. And so we are seeing at the same time that we have tremendous ethical demands and professional demands being placed on nurses, that some nurses are also losing their jobs. Now, it'll be interesting to watch long-term and see what happens. We know that there's a phased reopening of state economies that's happening, but there are also concerns, as I'm sure you're all aware, that this is happening too soon in many states and that we will see subsequent waves of coronavirus. And so, but with the reopening, we might see a return and a resumption of things like appointments and elective procedures. Open questions, of course, about whether patients will feel safe to come back in for appointments or if they'll continue to forego medical care that isn't strictly necessary. In some cases, we know they're even avoiding care that is necessary. But it might be too late for some of these nurses to get their jobs back, even with the reopening. And there's particularly concern for rural areas in America. And we know these are areas where there are already nursing shortages and healthcare disparities. And I think this is really an area to watch going forward, to think about what is going to happen in terms of workforce availability and also what it means for patient care and health disparities going forward. So I've put a lot of issues on the table. I think there are others that I'm happy to talk about. And with that, I am happy to turn it over to questions. Thank you so much.
About certain nurses who were fired for actually wearing a mask to work because they were like wearing it in the hallways, and apparently the hospital had a policy, you can't wear a mask in this hallway, and they would wear it because they would like, I want to feel safe in this pandemic, and get fired. What kind of legal recourse might some nurses have if they wanted to sue their employer for termination?
Yeah, so the employment protections are such an interesting question. I definitely have not been somebody who's practiced employment law, and I'd be happy, Scott, for you to weigh in. I'm sure you've done this as well. You're well situated to speak to it. We've seen a lot of talk about immunity and whether employers and others should be granted immunity. And so on the one hand, I expect we'll definitely see lawsuits and people who are complaining that they were unfairly targeted, especially given that there was a shortage of PPE, taking your PPE on and off is very dangerous. We've seen subsequent recommendations that we should all be masked all the time when we're within 6 feet of people and in public. So I think the nurses now can point to good evidence that wearing the mask was not an inappropriate response.
Right.
You know, my own family, we had a doctor's appointment at Children's Hospital of Philadelphia that we couldn't avoid, and we had to wear masks into the hospital and be pre-screened before we even went in. So I think we'll see competing tensions between a desire to have immunity and some good arguments. What are your thoughts on it?
It seems, when I read the stories, it seems strange to me. It just seems like, if that it really is in the employment contract that you can't wear this mask here, it seemed like it would be, maybe it would violate public policy. It doesn't seem to make good sense, especially now, or even just, so I think there might be an avenue, but I'd be curious to see how those cases go, because, and also just, it just seems like a very sympathetic plaintiff too. It's like, who is, you know, it's just, it doesn't make really good sense, especially, it's almost like, especially in a healthcare setting, to have that requirement to say that you can't wear a mask. It'd be different if this was some outside of a hospital or healthcare setting. It's like, where is this coming from? Like when I first saw it, it was like, this can't be real, but there were multiple reports of that. And it is, you know, it just felt inherently not right, that is happening. Another quick question I have is, so when this pandemic was initially unfolding, you mentioned how there were all the stories about lack of PPE going on. Has that issue gotten better, or is it still ongoing, do you think? Or where does it stand right now?
Yeah, so it's still ongoing. I don't think it's as bad as it was in the beginning. There's definitely, as somebody who regularly gets updates from the University of Pennsylvania health system, they have a huge and dedicated team that's worked really hard to try to ensure that there's adequate PPE. But even at Penn, based on the return to work training I did yesterday, people are being asked to take a brown paper sack, and they're being asked to store their PPE in that and reuse it until it becomes visibly soiled. And that wouldn't have been how that was handled 6 months ago. So, clearly we're still trying to meet demand, and we're not back to sort of where we were able to use it freely without thinking about putting it on.
Emily, I had a quick question for you. I know you wrote this really poignant piece on returning and feeling compelled to return back to nursing. In light of everything sort of happening, the protests, the lack of PPE, I wonder if you could walk us through some of sort of the calculus that you went through to make that determination, and both, in your nursing hat, your legal hat, and sort of walk us through some of your thought process and how you made that determination. Because I do think that there are many people in that similar position that may have, some other academic obligations or maybe some other work obligations, and are now really struggling with how they can best contribute to this.
Yeah. So, I think what's interesting here is that, my department chair, Steve Joffe, said at the time that the pandemic was really starting that unfortunately, as the state of the world goes down, the need for bioethics goes up. And there's really no shortage of roles and ways in which I think bioethicists can weigh in really meaningful ways into the response to coronavirus. And I have been really so impressed by the thoughtfulness and the dedication of my colleagues, particularly those who both sit in critical care medicine and also in bioethics, the reflection that they brought to thinking about, say, how to develop triage policies. But what struck me in all these discussions very early on is a point I made earlier in this presentation, which is that, we might worry about allocating ventilators. As I've explained to my daughter, you can take a piece of cake and you can cut it in half and you can give everybody a smaller piece of cake, but you can't really meaningfully cut up a ventilator and hand it out to multiple people. And so, we have these lumpy distributions, and people were talking about that in terms of ventilators, but nursing is similarly a finite resource. And so when you need people to operate those ventilators, or you talk about developing field hospitals with huge numbers of beds, I thought somebody has to be at all of those bedsides. And so it struck me, the more I reflected on it, that while there were things I could say as a bioethicist, to reflect on rationing and what it meant to ration in these circumstances, that I might ultimately better help this asymmetry between supply and demand by just rolling up my sleeves and lending a hand and going back. So, I did. I dusted off my clogs and I had my parents go through, all the supplies that I left in their garage when I moved back to the East Coast for grad school. And so they shipped me my stethoscope and other things. I was surprised to even find, my old pen light that I used for assessment. And I started working with the state of Pennsylvania to see about reactivating my nursing license. And it was really scary to do for the reasons I talked about, in terms of, I'm a decade out of practice. And I know that, a nurse's skills, I think that there's a half-life to those. And so, wanting to make sure that I was helpful, not harmful, not having an inflated sense of what I could actually bring to people. And so there's a humility in the decision. But, as nurses, we're taught to care for people, and to do that sometimes a sacrifice to yourself. And despite the circumstances, I felt like that was a really important thing for me to be open to. And I guess the coda to that story is that, fortunately, in Philadelphia, the field hospital beds were never filled, and people were not needed in the same way. And so I did not go back to the bedside, but it's certainly something I felt like it was important to grapple with and ask if I was willing to do that. And I was appreciative of the support I had from my family and others who were going to have to take on certain burdens to make that possible for me to do.
Yeah, I have another question. You talked about a little bit earlier, there's a certain dichotomy between like nurse bioethicists and physician bioethicists. Do you sense some of that similar discussion also with, like, there's a lot of discussion of physician burnout and nurse burnout? Do you feel like sometimes there's a dichotomy, people discuss it differently? And do you think burnout with the nursing profession is being talked about enough right now, especially in the context of COVID? Because I imagine it has to be an overwhelming burden for the profession right now.
Yeah, it's hard to imagine, reflecting on my own ICU experience, how hard it is to lose a patient and to think about this relentless, caring for people in really intense and difficult circumstances and losing large numbers of them in an ICU setting. I think burnout will be inevitable, unfortunately, for some people. In nursing, for a long time, there's been so much discussion of moral distress, circumstances where nurses know what they should do, but feel that they can't do it, whether that's because of power disparities or hierarchies, or being worried about retaliation, or not thinking anybody will listen if you speak out. And I was, in the great before February, I was at a nursing conference, and it was interesting to hear some nurses who were really actually quite upset at the suggestion that doctors might experience moral distress. And then there were doctors who were very upset that nurses felt like moral distress was theirs alone. I think ultimately what it comes down to is that we all do encounter similar ethical issues, but we experience them in different ways. And that's one reason why I think nurses need to be at the table and talk about these things and how issues affect them. So just to pick one example, I was routinely involved in withdrawing care from patients at the end of life. And we know, I'm sure everybody on this call knows, that there are huge questions about the ethics of withdrawing care, the killing versus letting die distinction. But, the doctor would write the order and walk away, and I would be the one who was at the bedside to talk with the family and maybe give a patient a last shave and hold their hand. And, actually was the one who went in and turned on the morphine drip and turned off the equipment. And so, I would never deny that my physician colleagues had challenges dealing with those circumstances. Those were their patients as well. But my experience of it was different, and there has to be room to talk about both of those experiences.
No, yeah, absolutely. Yeah, go ahead, Lynette.
Great. We have a question from an audience member who is asking if you wouldn't mind sharing your thoughts on some of the disparities in healthcare, and if anything that nurses can do in terms of the models of care, if you had any insight on or observations as to whether they can affect or impact some kind of change in order for these health disparities.
Thank you. I think that's a really troubling question, and one that I've been grappling with a lot over the last week. And I have to say that I think I should have been grappling with it a lot more for a lot longer. But over the last week and thinking about it, this is, it's institutionalized racism, and it's systemic racism, and nurses have a role in being fierce advocates. We know that for all of our patients, but really speaking out and speaking up when we see instances, and acknowledging too that the patients who come to us that are sometimes labeled as difficult or non-compliant or otherwise maybe undeserving, or things that people worry about, that oftentimes there are systemic injustices that have led the patient to be in that situation. And it's also about educating yourself about maternal mortality rates and how that affects Black women. And so I think in our practice we can do that, but I have actually been quite heartened, and I know that this is controversial, but to see nurses involved in protests and putting their voices out there, because ultimately I think that while it's important to be an advocate at the bedside, that it's really probably time for us all to be advocates in a much larger way.
Okay, I don't see any other questions right now. So Lynette, I'm going to pass it back to you to kind of wrap things up.
Just want to say thank you to our audience, and special thanks to you, Professor Largent, for contributing to this very necessary discussion. I think, one of the reasons we wanted to even have this forum is really to shed some light and really to give more oxygen to a topic that we feel like is sort of buried under some other topics that might be deemed more necessary and more urgent. But thank you again, and thank you to our audience for tuning in. Next week we will be here back again at 11 a.m. and we will actually be talking about public health law with Professor Lindsay Wiley. So thanks again for everyone. Thank you so much, Emily. Thank you for everything that you do and for your advocacy and of course your work in academia. I want to also congratulate you. I know I didn't mention this before, but for being selected as a Greenwell faculty scholar. So some good news in a time that we're surrounded by such negative news. And we hope to see you back next week again. Thank you again.
Yeah, I'll definitely be back for
Thank you.
Thank you guys so much.
Thank you so much. That was great.